Hey everyone, it's a podcast. Welcome to the CPTJ podcast episode 2. I'm Blaze Robson, and we got Ashley Berger on here with us as well. Today, we're going to be diving into the topic of where you go between the intersection of safety, performance, clinical reasoning when you're assessing a cardiac patient or a possible cardiac patient coming into you, maybe through a direct access setting or whatnot. So today, we got a pretty cool gal helping us answer that question. We got Dr. Karlyn Green coming in talking to us about her article and what she found is really important to use to assess anything from questionnaires, clinical outcome measures, calculators, all that good stuff. And we might have peppered in a few jokes in for you too. But now, Ashley, tell me a little bit about our guest.
So, as Blaze mentioned, we are interviewing Karlyn Green today. She is a girl boss who drinks black coffee and has accomplished a million things. She is also an assistant professor at Campbell University's Doctorate of Physical Therapy program. She completed her Doctorate of Physical Therapy at Mount St. Mary's College. And she also completed a residency with Healthcare Partners in Kaiser Permanente for orthopedics and a residency with Duke University for cardiopulmonary. And she now is board certified in cardiovascular and pulmonary physical therapy and orthopedic physical therapy. She is passionate about research that combines both orthopedics and cardiopulm disciplines. And her previous publications include topics such as restrictive lung disease, COVID, advanced heart failure, and she is also, to top it all off, an active member of the Academy of Cardiovascular and Pulmonary Physical Therapy. Get ready for Karlyn Green. Welcome, Dr. Green. Thanks for coming on the podcast. We really appreciate it.
Yeah, thank you for having me.
Yeah, of course. So, we kind of just want to get into what inspired you first to become a cardiopulm physical therapist who also has her orthopedic specialty as well.
Yeah, I kind of came to it very, very randomly. Cardiopulm has always been one of those things that I absolutely loved. When you're a kid and you're doing the science fair, I'm always picking the like, let's learn about blood and let's learn about valves.
Mhm.
And my grandpa was one of the oldest living recipients of the artificial heart valve when he passed away.
Whoa.
Oh,
Yeah, which was just so crazy. He had one of those old like ball and cage artificial valves.
Yeah.
And so he would always teach me about that. And then my other grandpa had heart failure. And just this random little thing, my first job ever, I was like 13 years old. EKGs used to only come in a very long strip.
Mhm.
And so the doctor would come behind and they'd write lead one, lead two, lead three on the paper. And I would come behind. I had this little machine and it would like cut out the lead and so I would like put it in this little machine. It would cut out the lead and it was like V1, V2. And I was like, I wonder what these numbers mean. And it was just so that you could look at a 12 lead EKG on one sheet of paper. And that was my first job. And I got paid 25 cents per page.
Wow. I hope you did a lot of pages each
I
day.
did tons of pages. It was mindless. It was mindless work, and you just kind of sat with this little machine. And I always wanted to know what they were. So when I finally got to PT school, it was just like this light bulb, and I absolutely fell in love with it in PT school. And then I was so influenced by everybody else who just absolutely loved ortho. And I was like, why does everybody love ortho?
Mhm.
Maybe I don't get it. So I did my ortho residency to see if I understood it better, maybe it would click and I would really love it. And I
Oh, so
did
you went in
really,
like
oh,
not loving it. Sorry to
I
interrupt you.
yeah, no, no, no. I
Oh,
was like,
okay.
maybe I just don't get it. And I went into it, and my residency was awesome. And I absolutely feel like I am the PT that I am today because of that residency. I just learned so much about how to ask questions and how to differentially diagnose and like really dive into pain. Um, and then I did ortho and travel for a bit, but cardiopulm was always kind of in the background. And so when I chased after the Duke cardiopulm residency, I absolutely just dove in and fell in love, and I haven't looked back.
Wow.
So yeah, kind of an interesting, weird way to get here, but I love where I'm at. It's super fun,
No,
and
that's
every
like,
day is like a new challenge.
and it's such a niche story that brought you here because I feel like a lot of people probably didn't have that job. That's that's so
Right?
interesting. I didn't know that they came like that.
this was like, I mean, back in the 90s, we were living out in California, and I don't even remember how I got that job, but
And at
yeah, I just
13.
wanted to know what the ones and the twos and the threes were. And now I know.
All
Yeah.
right. Full circle.
And that's even so unique because I know I've heard of people getting their CVP specialty and then also like their acute care specialty because usually those are done like in tandem, not at the same time. But yeah, I looked whenever I was reading through, I went OCS. So it was really neat for me to see too. So that's super cool.
Yeah, they hardly people don't want to think about them together. And I am one of those people that is constantly like, what else can I do? And it's so common for me to be in the hospital doing joint mobs on
Oh,
patients. And then my colleagues will come behind me and they're like, the patient's asking for whatever you did last time, and I'm reading your note. And I'm like, come on, guys, it was just like an anterior glide of the tibiofemoral joint. And they're like,
oh,
I don't remember that.
I remember. I remember one time because MOBs are one of my favorite things. I
Yeah.
loved during PT, and I remember there was a mentor hour session during my residency that I had, and some guy was like, "Yeah, I'm randomly having some knee pain from this, and that." And I think I did. It was like a uh, A to P on the
Yeah.
tibia, like to get some more flexion. He's like, "Wow, this is great." And then I look at my mentor, and they go, "Yeah, I haven't seen that in forever. That's been a while." Pull that out of my
See?
toolbox,
Yeah. I mean,
holster
we
it
have
back.
so many tools as PTs. It's crazy that we don't try to use them all in the human that's in front of us.
Yeah,
I think it just makes us a much more well-rounded clinician when we really dive into our full tool box, like you're saying.
yeah, and I loved what my coordinators had told me before too, especially with cardiopulmonary. I guess it's unique in that way that almost any diagnosis that you see is going to have some cardiopulmonary aspect to it. Whether it's like a vascular thing, if someone has a stroke that you typically think would be a neuro, if it is a trauma orthopedic thing, okay, guess what? Your vessels are probably going to be absolutely annihilated after what happened to you. So that's the cool part about cardiopulm that I find really interesting. That I think it could really work into a neuro residency, or it could also work with an OCS really well.
Yeah, that's one of the cool parts about the program that I teach at. We have this like it's one time a week where we have 2 hours where we're providing free physical therapy for the community, and the 2 hours is started as neuro,
Mhm.
and I am in there all the time, and I'm like listening to people's lungs, and I'm like, this guy needs airway clearance, and I'm doing airway clearance on the side for our patients, and the students are in there with me, and they're doing the airway clearance on this outpatient, and we're talking about, like we're setting people up on EKGs, and we're just like all of that learning that happens when you're just, like I said, seeing a human as a human
Mhm.
and
Mhm.
what can I provide to this quote unquote neuro patient, right? But like you're saying, there's a ton of diagnoses there that can be supported and use our skill set, especially as cardiopulmonary specialists. So yeah.
Well, and seeing all those diagnoses, at least like straight out of PT school, could be very overwhelming. So I always just like, I had a mentor who's like, treat the impairment, like,
Yep,
don't look at
exactly.
everything. Like, obviously, you have to chart review well, but like, if you
Yeah.
just get stuck in your ways on how to treat a patient, like the same, like each patient that has the same diagnosis the same way, then it's not gonna work out. So it's like, what
Yeah.
impairments do they have? Whether it's like more neuro-based or cardio-based or orthopedic.
Right.
Which I will say that I have gotten stuck a little bit, like after residency, being like, oh, I have a spine patient, but they're also in here because they need a heart transplant. But like, I don't remember spine things, and it's been like a whole thing. I've been studying up a lot more now after.
Yeah.
Yeah.
Yeah. It's so hard to like feel like the skill set that you had at one point is gone, and
Mhm.
feeling like, oh, I really need to brush up on that. But you're trying to get through your day to day. But it's totally worth it to brush up on those skills that we sometimes don't think about.
Mhm.
And I think on the outpatient side too, like our pulmonary patients can benefit so much from our manual skills. And I know Ashley, when I was in outpatient pulmonary rehab and cardiac rehab, a lot of times I would be over there just doing manual therapy, like T-spine mobs or rib mobs,
Yeah.
or, whatever it is. And then that patient all of a sudden can take that little bit of a bigger breath. It
Hmm.
goes such a long way in our pulmonary patients, especially.
Especially
So,
after a lung transplant, we did so many
oh
T-spine
my
moves
gosh.
and like rib
Yeah,
mobs and other things like that. Obviously, like after precautions were off for the rib mobs, but
yeah,
like
yeah.
it would help them a lot because you get so restricted.
You
Um,
do.
yeah.
Absolutely. Right. And is it actually a lung function? Is it a rib mobility issue? Is it a thoracic spine mobility issue? Like, and so I absolutely love like pulling in all the ortho background that I have and pulling in the cardiopulm stuff that I've learned along the way and trying to meld them together. So a bunch of my research is like I've had these ideas since residencies of like, why aren't we doing more of this? So now full-time faculty, I finally get time to do some research, which is really exciting. So
Yeah. And this research that you did, which we're going to be talking about a bit today about assessing the risk of a cardiac event before initiating aerobic exercise, that was meant to be for like all practicing PTs, not just like specialty PTs.
yeah.
So,
Yeah, this actually came from one of my clinical students when I was still working full-time in the hospital. We walked by this room and we had chart reviewed, and the whole time he's like, this name is so familiar. And so we're chart reviewing, we're getting ready, and this person had an aortic dissection, and we were getting ready to go see this patient pre-op and do some assessments pre-op. And he walked in the room and he immediately was like, oh my gosh, I know where I know this person from. And he says to me, we step out of the room and he's like, I've got to go get something. And we step out of the room and he's like, I saw this person. He had come to me. This was his first week with me. I saw this person last week on outpatient and I exercised with her. And now she's in the hospital about to get an aortic dissection repair in the hospital. And it was just this like light bulb moment for him and for me that a lot of times on the outpatient side, we are exercising patients without really, really thinking about whether or not they're at risk for a major adverse cardiac event. And so that was kind of the impetus for this research project. Like, are we actually assessing the risk of a cardiac event before we're exercising patients in across all settings? And maybe as cardiopulm experts, we are, right? Because we're constantly like thinking about that cardiac or pulmonary diagnoses. But I wanted more PTs to be thinking about it. And there's so much literature out there that says that we're really not doing the great assessment that we should be doing as PTs, especially in the outpatient setting.
yeah, I saw like 15% or something like
Yeah.
that were saying that they actually measured vitals in that
Yeah,
setting. Is
it's
that it?
crazy. It's
Yeah.
crazy how low. I mean, and we talk about it in PT school, and you're constantly practicing vitals, and vitals are vital, and we all so we feel that in our hearts, and then our students get out there and they see that it's not happening, so then they don't do it, and then it just perpetuates that. Like lots of PTs are not evaluating vital signs, and they say, "Yeah, go warm up on the bike." Right?
Yeah.
Or yeah, we want to support your goal of doing physical activity. You should walk 5 minutes when we haven't done an actual assessment to see if it's safe or if we're getting a good cardiovascular response. So that was kind of the impetus for this research project.
Yeah. Were you surprised? I remember reading through it. Were you surprised by 15?
That how low it was?
Yeah, were you surprised by 15 or were you like, oh, it might be 30 or something, but 15%?
No, I that the Rich Severin and his crew did that article, and that number surprised me, when it came out. It was so low. And to be somebody who's in PT programs like harping on this, you gotta take vitals, you gotta take vitals, to then see that number come back, it blows my mind.
I remember being on my first rotation. It was in an outpatient setting. And I was just, the first few days, you just watch your CI, see how they do their evals, get an idea about it. And one of my mentors in PT school said just what you said, like vital signs are vital. There's a reason why you take it. You might catch something, yada, yada, yada. And then throughout the entirety, I didn't think I saw one vital sign being taken that wasn't me doing it. And I was like, I thought we were supposed to do this stuff, and then you get the excuse of, well, I mean, you could, it's not wrong, but they're not here for something like cardiac related, so you really don't have much to worry about. And so I'm just like completely jarred. And then
Yeah.
whenever I'm reading through your article and I saw like you were mentioning the Severin article, I was like, okay, I'm not surprised that a lot of folks don't do it, but I did not think it would be 15%.
Right. And then you look at the reason, there's been a couple of other articles that have looked at why we're not doing them as physical therapists, and it's lack of time and then lack of perceived importance,
Oh,
It's crazy.
which just hurts, right?
I had a similar experience to you, Blaze, a little
yeah.
bit with my first clinical, which was also outpatient. And I don't even think they owned a blood pressure cuff.
Oh,
I know, really bad. And the majority of our patients, looking back at the time, I didn't realize this. Like, majority of them definitely had heart failure, like so much edema in their lower extremities, like a rather older population. And I think there were a good like handful who we ended up sending to the hospital because they were not doing well. But nobody checked vitals before they were sent either. And like it was but then as students, we see that and we're like, oh, well, maybe like once we get out into our own practice, like we don't need to do that. Like if you're not as passionate about it and you're like, well, these people have been practicing for years aren't doing it, so why should I be doing it? So I
yeah.
think it's like just needs like a cultural shift a little bit.
It really does. And I mean, other literature that looks at like why students don't do it. And it literally is like the culture of the clinic that will impact a student's impetus to take vitals moving forward. So we really just, our clinical instructors need to demonstrate good, good behaviors and good, just like doing the tasks, like
Yeah.
just take them. So I think that's the other part of the reason I wanted to do this scoping review is because if we're not going to do vitals and we're not going to take that extra step to build a culture where we're at least assessing vitals on initial evaluation, can we be doing something else to help us assess cardiac risk, right?
Mhm.
Mhm.
So that was the other thing. Is there something else that's a different kind of healthcare provider? What are other people doing that we maybe should be doing that could help us identify cardiac risk if we're going to be the 15% that right
Yeah.
right with such a low number, is there something else that we could do? So
And I know in your article you discussed quite a few of these like other methods of assessing like readiness for
Mhm.
activity. Can you kind of go through a few of those assessments and which ones you found were like most practical for clinicians and outpatient or can be inpatient as well?
yeah, I mean, this was definitely geared primarily towards an outpatient setting.
Yeah.
When I think about a scoping review is just like you cast this wide net. Like you want to know what's out there, what are providers doing? And I wasn't specific to physical therapy because I feel like we kind of know what physical therapists are doing. I wanted to know what other people might be doing, other healthcare providers might be doing that we could use, that maybe we're just not aware of because we don't think about it in the context of physical therapy. So we do this scoping review and we get a bunch of articles and a bunch of different methods to assess risk. And of course, because I'm thinking about it in the outpatient setting, we have to exclude a ton of articles because we don't consistently, as physical therapists, have access to lab values.
Mhm.
So, if somebody doesn't have a troponin, then you're like, okay, well, now I can't use that method, or a high sensitivity C-reactive protein, right? Like, how many of your patients on the outpatient setting are going to have that specific lab value? So, we ended up having to just exclude a ton of articles because physical therapists don't consistently have access to those lab values. So we came back and we landed with five different kind of categories of ways to assess cardiac risk. So the first one is just looking at the number of risk factors, right? We
Mhm.
all know our cardiac risk factors, like how many make somebody more at risk for a cardiac event. Is it one? Is it two? Should I be more concerned if they have three? Like, what's the magic number there? And so I wanted to see if there was some information there. So assessing cardiac risk factors. And then patient questionnaires was another category, different questionnaires that the patient can fill out to help you kind of weed through some of those cardiac risk factors. And then risk calculators, which I had never heard of until I really started teaching and starting digging into the literature. And then some of the other ones people probably think of are like your physical examination assessments, like your waist to hip ratio, right? We all know that that one has some assessment of cardiac risk. How much are people using that? Is there really good data to support that? And then exercise testing was the last category that we found. And so we took all of these articles and we kind of divided them into those 5 categories.
Okay, great. Thank you for sharing.
Yeah.
Have you found that one of the risk calculators is better, like over the others? Like, do you have a favorite that you use?
Yeah, so what I found is that actually the cardiac risk factors are have the best like odds ratios. Like you get a ton of data from assessing cardiac risk factors. So if nothing else, if physical therapists are just looking at somebody's past medical history and being like, oh, I see they have hypertension and they're a smoker and they have type 2 diabetes, that's three. I should assess this person's vital signs,
Mhm.
right? They already have three cardiac risk factors. So the statistics are a lot more prevalent with just assessing the cardiac risk factors. The calculators, though, which I think is super helpful as a physical therapist, the calculators will tell you if you're putting in the information. And now everything's online, right? Like MD Calc has a million, easy calculators. You just type it in and it tells you what your risk is. The risk will be like low, moderate, or high. So if you're using a risk calculator, you're typing in the information. Some of them don't need very much information. And you could easily get them either from conversing with your patient or by taking some of the like vital signs, like getting a blood pressure. You're putting in that number and it's telling you low, moderate, or high. If
Mhm.
somebody's high, maybe you decide, okay, this is the person that I really need to be careful with, and I should do a small version of an exercise test and see how they cardiovascularly respond. Or maybe that's the person, if you don't feel confident as an outpatient therapist, maybe that's the person you're like, I do think that you should refer back to your primary care or cardiologist to get more testing, right? If you don't feel comfortable with that. I know a lot of us as cardiopulm people were like, yeah, let's see what happens. Let's assess their cardiac response, their cardiovascular response to exercise, but an outpatient therapist may not feel as confident with that. So I love the Framingham. It requires the least amount of information.
Mhm.
And it clearly, as somebody who is terrible at math, is very easy to access online. And it calculates it for me and it just spits out a number and it tells you low, moderate, or high. And 10% risk or 20% risk in the next 10 years. So it's really easy to do if you just take that little bit of an extra time.
I used
And
that
what
one a bit in residency, and there was another one that also took into account, I think, ethnicity as well and like socioeconomic factors. And I can't remember what the name of it was, but it was like pretty thorough.
There's a few that are super thorough, right? So
Mhm.
it will ask more about ethnicity and background. And so there are a few that require more information. I find that the Framingham is the fastest, and I tend to have access to that information very quickly.
Mhm.
You also have to be careful. Some of them are used for patients who do not have a diagnosis of coronary artery disease, and
I
some
see.
of them are for patients who have coronary artery disease, and some of them cannot be used with patients who have diabetes. So you
Okay.
just have to be careful with some of the cardiac risk or the calculators, excuse me, and just making sure you're picking one. Framingham is pretty widely
User
used
friendly.
and easy to use.
Okay.
Yeah.
Gotcha. Gotcha.
And when it comes to the questionnaires, my mind's going, and if I was an outpatient PT, I'm gonna ask three or four questions to get like a quick and dirty. Okay, this person's at risk because they're saying their quality of life doing this, this, and that are tough. Is there a questionnaire that you prefer or might just be a go-to within that setting? Because I know it might be different if someone's staying acutely because what you're looking for is going to be much different compared to someone who's just coming into your clinic, especially if they're a direct access patient as well.
Yeah. So what's so interesting about the questionnaires is that the ACSM guidelines, which I feel like we all go to whenever we're thinking about exercise testing or prescribing exercise, the ACSM guidelines recommend the PARQ, the Physical Activity Readiness Questionnaire. And if have either one of you ever done it with a patient?
Yes.
I have not personally.
Okay, when you put some their results in, and if they have any cardiac risk factors, at the end it spits out, and you're like, oh my gosh, I'm doing this whole questionnaire. And at the end it says, refer to an exercise specialist.
Mm-hmm.
Like, is that is
Me?
that still me?
Like, am I that
Am
specialist?
I that? And you absolutely are, as a physical therapist, you are the exercise specialist. So I love that the ACSM guidelines are at least pointing us to a questionnaire. But
Mhm.
at the end of it, if it just says refer to me, then I'm still stuck at this like, okay, well now what do I do? Are they at risk or are they not at risk? And so I think what I learned going through this whole project and like looking at all this literature is that I think it's a great place to start. The purpose of the PARQ is that the patient fills it out. And there's that informed consent at the end that says, like, I agree to exercise, right? So, for a lot of this, it's super helpful to have the patient fill it out. It does require a high level of health literacy if you're going to just hand it to the patient, because it is a pretty extensive form. But what it does is it highlights the cardiac risk factors.
Mhm.
So if nothing else, if you're like, I just want a questionnaire that I can hand to my patient and it will tell me, yes, 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 okay, I have three cardiac risk factors, right? Then you can at least take that information and be like, okay, they're at a higher risk. I really need to be careful with this patient. I should do vitals on this patient because they're at an elevated cardiac risk just from the fact that they have the cardiac risk factors.
And with like what Blaze mentioned a little bit about, I know you had said something about direct access, and that kind of made me think there are some now direct access states like for physical therapists. So I feel like this is something that should be extremely important as that's driven forward. So do you see like any like do you perceive any shifts or changes in how outpatient physical therapists are going to be approaching this?
I think that as a cardiopulm, like the Academy of Cardiopulmonary and like we need to be pushing a narrative that we all can get behind. We are pushing vitals are vital, right? And we have been. And then we do these studies and we're like, okay, but are other people listening? And we find out that 15%, right? We're not getting to the outpatient orthos, the outpatient settings, right? We're just not getting to them because they don't feel like it's what like worth their time. They don't have the time and they don't think it's valuable. Um, so in my head, I think this was a step one is to see what's out there. And to me, step two is for us as cardiopulm experts to come behind and say, okay, we feel like this is the best approach, and then we push that forward. So in my head, it was always like, do this scoping review and then get a group of cardiopulm experts together and really talk about it in the way that we're talking about it now. And send out that narrative of this is going to be best practice for our outpatient orthopedic PTs or our PTs that have direct access. Like this is what you should be looking at. Um, but it's going to take a lot more than one small scoping review to I think change the culture that is our PT profession.
Yeah, that brings because that was probably one of the questions that I had the most reading through your article was how do we convince these folks? And I know we touched up on it before. Do you think it starts off at a policy? per location, like per outpatient setting? Do you think the change comes from a group like this talking about, or is it really starting with the students who are gonna go in to an outpatient, it might not even be exclusively an outpatient clinic, and say, "Hey, I'm not seeing that any vitals are being taken, but I don't want to risk the patient myself, so on and so forth." Where do you think that change is?
I think all of the things you just
Yeah.
mentioned will happen, right? Like this is a great starting point, because we can read articles and then we just, we process that information and you're like, huh, uh-huh, I'm either going to use that, I'm not going to use it, right? Or I'll think about that next time it comes up, right? So this definitely helps, like talking about it and really diving into the topic is a great place to start. I think we need to continue to push the narrative that we're clearly not doing a great job of taking vitals, and we need to continue to educate. You're kind of hitting on the reason I'm in academia.
Mhm.
You hope that you're at least reaching a few students and you're changing their mind and you're giving them these tools so that they go out to clinics, right? I have 45 students in my classroom and they're all going to go out and tell their CIs that they need to take vitals, and you hope that that happens, right? And you warn them that they're going to be in clinics where they're not going to see it happen, and it is okay to advocate for your patient and advocate for their safety, and especially we're talking about major cardiac events, acute coronary syndrome, myocardial infarction, sudden death, right? These are things that you say to students and their eyes get big, right? Because they never want it to happen on their watch. And part of that should be education that, these things need to be thought of and we need to be better about it. I think the other really, we're kind of at a point where primary care is becoming a specialty, right? And like, who's in the room advocating for this kind of information, right? I don't know.
Mhm.
If
Yeah.
anybody knows who's in the room, like I would love to be in the room, because I do think we need some level of like some cardio palm presence where we're really talking about like if the standard is to take vital signs, that is fine. If the standard is to assess cardiac risk factors, that's also great. There are other tools, and I don't know if I have a favorite. I feel like as long as you're thinking about cardiac risk before you just say, yeah, warm up on the bike,
Yeah.
I'd be happy.
Yeah, I mean, that's great. I think that I would rather a student learn that from you in your class than have a traumatic experience with the patient and then start taking vitals. I'd rather them do it right out of the gate than have a terrible experience with the patient and then get scared into doing it
Right.
because they have a bad experience.
And my student that I talked about in the very beginning is a perfect example, right? How terrible is it to say, I exercised that patient last week and now they're here in the hospital getting ready to have an aortic dissection repair.
Yeah.
And it could have gone terrible, right? And you just let them warm up on the bike, or you're saying, yeah, it's okay to go work on your aerobic capacity in the neighborhood, and you don't actually know if they have a good cardiovascular response. And you're just like, yeah, start at 5 minutes, work yourself up to 10, and you're sending somebody out into the world to exercise by themselves in their neighborhood. And then, of course, this is what we hear about, which is the person that goes out for a walk and then, they sudden cardiac death or myocardial infarction or, whatever the terrible event is. So, I just think if we are thinking about cardiac risk in the outpatient settings and we're just doing a little bit to say, okay, this person has more cardiac risk factors than one, two, the literature actually says that once you get into the two category, you're closer to a moderate risk. And once you're above two, you're in the like high risk. So those are the patients we really need to monitor, even if we're doing, the smallest amount of exercise, 5 minutes, you do vital signs pre and post, and just make sure that they're having a normal cardiovascular response to exercise. That person is going to be so much more safe doing that 5 minutes out on their own, knowing that you just took their vitals pre and post, and you know that they have that normal response to exercise. And if they don't, then you refer, right?
I
No
think,
Oh yeah.
harm.
oh, sorry, go ahead.
No, I was just going to say there's no harm. Yeah, it's
Yeah.
going to take a little bit of extra time, but you could potentially be saving somebody.
It kind of makes me think that we should have bracelets that say like something about having cardiopulmonary risk factors, like a fall risk, but it's like maybe like monitor vitals, like on a bracelet or something whenever a patient comes in. Because I know at
I
least like
love
in
it.
a lot of the clinics, there's like they have the little necklace and it says fall risk on it, or they have a
Mhm.
bracelet or something like that. And then it just like, because it's not always the physical therapist checking in the patient. I know like some places it's like a tech or a
Right.
PTA or like, which obviously PTAs have a good base of knowledge as well, but you know, like it may not be somebody who knows the patient and then they don't chart review them and then they're there and they don't actually check their vitals. So maybe nice to have something like that.
And I
What I
mean, even like if it's a PT tech, you know, I know legally there, who can take vitals, who can throw on an automatic blood pressure cuff. It doesn't have to be a manual blood pressure cuff that requires all this skill, right? So it's just, there's so many ways to go about it. I just think we need to really elevate, we're all getting our doctorates now. And
Hmm.
now we're getting direct access. And now we're chasing this primary care specialty. We really need to be thinking about these things.
and with the bracelet idea, if I ever go back into the outpatient setting, I'll get one that says WWKD. What would Karlyn do? And I'll know immediately to get my blood pressure cuff out, get my stethoscope and everything.
I
That needs
love
to be
it.
We could
standardized across all
we
clinics.
could we made t-shirts for the section for this
Yeah.
meeting. Do you think we could do bracelets too? Let's talk to David. Let's see if we can't get on that.
David, all right,
Let's
we're
get it
coming for
going.
you.
Yeah.
He'll hear that while he's editing, in case I forget to tell
Gosh. Well,
him.
and like even we're so good about doing our vitals of our t-shirts every year, and new, and I completely support the academy, and I love that we do that, and I rock mine all the
Hmm.
time. And my students see me, and I will be testing something like ortho practical, and they'll go and they'll grab their blood pressure cuff because they think I'm watching, and they're like, "I'm gonna use this," and I'm like, "Yeah, you should use that, whether I'm here or not. It's not about me. It's like do the thing." So yeah.
And
Oh
and
my
speaking
God.
about like even jewelry or stuff like that with the new Aura rings, the like Apple Watches now, what
Ah,
education do you give to patients in an outpatient setting who have or I mean, I think you could get a cheaper band or something like that now. I'm not sure. But what part does that have to play in all of this too? Because I know that like my Apple Watch, I mean, the settings turned off. You hope I don't need it like to check for AFib or something like that. But yeah, where do you see that going with all this stuff too? I mean, it doesn't need to be super difficult. I feel like if you're in a setting and I'm like, "Hey Ashley, before we get started, do you mind checking your heart rate real quick for me on your watch?"
yeah.
Right. It doesn't have to be hard. And so many patients have, these devices that they have access to. Um, Imagine a world in which we just did a quick assessment of pre and post vitals. We knew that a patient had a good normal cardiovascular response, and then we actually prescribed aerobic exercise in a good capacity, in a smart capacity, in a safe capacity where you're making good clinical decisions. And then you give them their own watch to monitor themselves. Like it doesn't have to be difficult. We just have to go that extra step of saying, this is my patient's goal. They want to lose weight. They want to get, walk longer distances, right? Like, what are their goals? And if exercise is part of that, let's do that extra step to really make sure that they're safe. We're signing off that they're safe, right? Or if we find something, we're referring back, and then we're teaching them how to use their devices that they're wearing to be successful, right?
Yeah.
And if nothing else, we're teaching RPE,
Yeah.
right?
Well, and it's
Going back
Yep.
also
to
nice to have that real-time feedback, especially for the patient.
Yes.
Sometimes if they're more like visual learners, or I don't
Yeah,
know about you guys, but whenever I'm using my watch and I get like that instant serotonin boost if I like hit my step count or something, whenever it like goes
right.
up. So it's kind of like that could be also an incentive for them to self-monitor outside of the clinic.
And so many of the watches now will give you like, okay, this is your heart rate zone one, zone two, zone three. I want you working out in zone two, right? They've made it easy for us to prescribe exercise. We just have to know that it's safe, and then we do our jobs, and so much of it is taken care of through these, new devices, which is great. And I absolutely love it.
Yeah.
So, and then you get to there are really cool new devices. I don't know if you guys have seen the Cardia
Yeah.
portable device. There's two different versions. One of them is like it's literally like a half of a credit card, and you put your thumbs on, and the EKG,
Yep.
you can get like the up to six leads coming into your phone, and you can use that to like monitor their actual rhythm with just having them hold their thumbs. It's super accurate. I bought one for my dad because he was like, I'm not sure if I'm in AFib or A-flutter.
Okay.
And so he literally sends me the picture of what his cardio device is doing. Like there's so many new awesome tools. And then they have the credit card one that you can actually just put in your wallet and you pull it out
Oh,
and you put your thumb on it. Yeah. So you can just put it in with the rest of your credit cards. There's so many cool new devices that are out there to support patients really advocating for themselves, being safe about it. Right. So we just have to be better about using the tools that a patient has. So,
well, and so many patients go unmissed if they're not going to appointments like this, unfortunately, or if they don't have like the access to that sort of stuff. But it is really cool to see how far technology has come, and I'm sure that it will get less expensive as time goes on too.
yes.
I actually don't
Yeah.
know how expensive those are. Do you know, like,
Yeah. The cardio was like $110 on Amazon.
okay, so it's
Oh,
not like crazy. I thought it was going to be something insane because I feel like all medical devices just,
Yeah. And that was for the six, the Cardia six, which gave you the six different leads.
wow.
There is a cheaper version that only gives you the one. But there's obviously I have nothing to disclose. I'm not getting any money from Cardia. There are
We're not
other
promoting
devices,
it on here right now. This is
there
not an
are
ad.
other devices out there. That one just gave me the opportunity for him to screenshot his EKG and send it to me because he's in California and I'm in North Carolina. And so, got to worry about dad and his
Of
AFib.
course, of course.
So,
Oh, that's so cool.
yeah.
All right, well, we're kind of coming to the end of our time, but Blaze and I have some rapid questions for you. Blaze,
Okay.
do you want to do every other question?
that's fine with me.
Back team. Okay, you go first.
Uh, I'm on my own little hunt for. I'm actually glad. So we have a standard like amount of rapid fire questions. I've been on a hunt like for the holy grail of outcome measures because I've been trying to think of one to use like a questionnaire within the hospital I work at. But for you right now, 2025, what is the
November
most
20th. Sorry.
November? Yes, November 20th, 2020. No, we need to get specific with this.
Yeah.
This needs to
Right.
be logged.
Right.
What is the most underrated clinical outcome measure that you can think of right now?
That I'm supposed to rapid fire this.
Yeah, this is
Yeah.
rapid fire.
10 seconds.
This is the
10
CPT
seconds.
CPTJ podcast. We don't mess around here.
Oh my gosh. If you're saying outcome, then I'll give you Park U.
Okay,
Nice.
I love it.
On par with this too. Pun
Hmm.
Yeah.
intended. Okay.
Yes.
Okay. One book every PT should read.
What about The Silent Patient? Have you guys
Oh,
read it?
Mm-mm.
no.
It's fantastic. It's a thriller book, but it really made me think about how I'm communicating with patients who maybe are not talking back to me. These are hard.
These are
Just
tough.
wait.
Okay, so before you start writing whatever it is, manuscript, you're writing a new exam question. What are you ordering it for something to drink? Do you have a comfort drink like a coffee and tea, anything like that?
Black coffee.
Oh my goodness!
Oh.
Holy cow! I'm a little.
I used to put a lot of sugar in there, and it just got to the point where I had to go black coffee.
All
I
right.
feel
Girl
like
boss.
I'm not a coffee drinker, but every time someone says they just drink black coffee, I'm like, you probably like have nails for cereal with your milk. Oh, you just sound so tough when you say that.
I am 100% a product of my upbringing. I'm from Minnesota. We drink coffee all day long. The coffee pot is on. We're 10 o'clock at night. You're still drinking coffee. It doesn't have to be decaf. And you go right to bed. A cup of coffee and a nap, and you're set.
Oh my gosh.
Sounds like my boyfriend, his family is Cuban, and every time they're with his family, his Lita always puts on like some sort of coffee or espresso
Yeah.
or something like that. And it's like
Mhm.
also like 10 p.m. and everyone's
Yep.
drinking it except me because I literally cannot sleep if I have coffee that late.
Here, Ashley,
Um,
you take the next two, and then I'll
okay,
take the
okay.
last two.
Um, so any advice for those hoping to become more involved in research? Because it can be kind of a daunting thing to get into.
Yeah, find a mentor and just put in the time. It is very daunting to get into. I was always one of those PTs that I had so many ideas, and I really struggled with trying to get my ideas up and running. So if you have somebody that is good at research and can mentor you through the project, it is so much more smooth. And I continue to get mentoring. I have published a couple times, and I still to this day feel like I have no idea what I'm doing, but I just keep trying and I just keep getting my ideas out there and seeking mentors. So seek a mentor, get your idea out there, see what happens. It can be a flop and it's still a great learning experience.
Yeah, I love that.
Oh.
Okay, thank you. I've also wanted to get into research a bit more, and it is very daunting to like where to start.
Yeah.
So
And
having a
I
mentor
feel
has
like as
really helped.
clinicians, we see things and we're like, oh, that's like I know what I read, but that's not what I feel, and
Mhm.
that's not what I've seen. And that was my last research project, was looking at outcomes pre and post LVAD and heart transplant, because it felt like I don't know how good they were before, but afterwards they just feel like I'm working so hard to
Mhm.
rehab these patients, and like what they feel like they're eventually going to bounce back, and do they bounce back?
And you
And
see
so
them bounce back and your time
yeah,
with them.
sometimes it's built out of like your research idea comes out of like the thing that you feel on a day-to-day basis, which is like, I'm so tired of rehabbing these patients, and like, why is it so hard? And so no, like we just need people to be out there researching even the things that we feel on a day-to-day basis to see if they're actually true or
And
if we're
what's
just
the
complaining.
what's the name of that research article in case anybody wants to go read it?
We called it Thrive, but it has
Oh,
to do
right.
with the
Yes,
Thrive HF study. So I'd have to go back and look at what the actual title that we
that's
landed
okay. I
on.
think people will be able to find it, and we can also get David to link it because David's great. And
Awesome.
next question. Favorite place to hike or walk around Raleigh, Durham, Chapel Hill area?
Oh, I was going to say in the world, because California,
Oh,
Yosemite is my favorite place.
that's a great answer too.
Here I like to go to the Eno River and walk around the Eno River. But I am a huge hiker. I love to hike. And my husband and I tend to take our vacations and go hike. And we absolutely had a ball in Yosemite. We just did too many miles in too short of amount of time. And we were so tired. And Half Dome is totally worth it. If you ever get a chance, and you win the lottery to go hike Half Dome, do it.
Right. I'll put it on the bucket list.
Yes.
Okay.
Yeah.
Last few questions with Blaze. Go for it.
Right.
So after you're done writing an article, or you're done sitting for your third or fourth specialty exam to get another whatever, that you'll probably have a five before you retire with the way that you're going now. What do you do to mind dump? Like, do you binge watch a show? Do you binge watch reading? What do you do?
I definitely am really good at watching terrible, terrible TV, like reality TV. I'm good at, the Love is Blind and all of the
Yeah.
terrible TV. I'm a huge fan of British Bake Off. Absolutely love that show. But I also do personally love to bake. It's one of my favorite hobbies. I just need excuses. So people tell me when their birthday is and they send me something that they want, and then I just go to town and I have so much fun baking. So a lot of baking, sometimes terrible TV.
Oh, I'm a big snickerdoodle guy, so I'll send you my birthday
Oh,
where I'm
perfect.
living right now. That's also
I'll
I love baking too, so I'm all for that. Kindred
It's so
spirits.
fun. Right before yesterday, last night, I finished my first sourdough because
Oh, wow.
everybody else in the world had COVID, and they're like, that was my sourdough era. And PTs, we were in the hospital trying to rehab patients on ventilators and figure it out,
Yeah.
right? And I'm writing protocols on like how to see a COVID patient, and we're stressed out, and everybody else is making sourdough. So I'm finally catching up to the sourdough. I'm finally having my sourdough era.
And to the last question of the podcast, and to me, probably the most important one. How many Hawaiian shirts do you own?
Stop.
One.
Okay, yes, we got one. We're on a streak.
I
What color
own
is it?
one. It's in my costume suitcase where I keep all of the costumes in case I ever need to dress up as anything.
Hmm.
So one Hawaiian shirt. How many was Rich?
Only like 10
Oh,
or 11.
oh,
Okay.
yeah, he was at 10 or 11.
Yeah, but I really thought it was going to be more. But I guess you can do every day of the week plus some. So
Oh
it's
yeah.
yeah.
He has his formal Hawaiian shirts, he has his everydayers that he goes through.
Mhm.
Oh,
Yeah, he busted out a few at the fall conference.
Mhm.
We saw a few. So
All right. So is that going to be one of our rapid fire questions we keep in for every
I
guest?
think that's gonna be my rapid fire question that I keep in for
Okay.
everyone.
love
I'll
it. I
expect
love
it.
it.
Okay, great. Well, Carla, thank you so much for your time. This has been
Oh
so
my gosh,
lovely. It's been
it was
amazing. This was
so
an
fun.
awesome topic that's so needed, not just for us, but for every single PT out there, students, even other clinicians, like any OTs or SLPs who may be like stumbling upon this podcast.
Yeah, I mean, I got my girl Sam. She's my OT. She was on my Thrive study, my LVAD heart transplant study, and she did a lot of work with the cognitive outcomes. And so we're constantly back and forth talking about, how does this apply to OT as well? So yeah, I had so much fun talking with y'all. It was so fun.
Likewise.
And just even, right, like whoever also is passionate about this, reach out to me because I do think we should have something to put out to outpatient, like a clear, not scoping review results because it's too much for them to read through. But it would be really awesome as an academy if we could, give a little more guidance. And if we stick with vitals are vital, we just have to get better at getting people to do it.
Mhm.
Oh yeah.
All right.
Yeah,
Well, thank you so much for your time. We really appreciate it. And
Yeah,
absolutely.
hopefully,
thank you.
we'll see you at another conference sometime soon. Are you
Yep, I'll
doing
be at
this?
CSM. You guys?
Oh, yep, CSM.
Oh, can't
Yep.
afford it yet. Still paying from the CVP trip to
Oh
Utah.
no.
Well,
But again, Carlin, thank you so much. It was so good to see you.
absolutely great to see you too. Nice to meet you, Blaze. Thank you guys for doing this. I know it's like a labor of love, but I really do think it's super worthwhile and hopefully gets more people to listen and care. So thank you
Yeah,
both for doing it.
of course. I
Of
mean, we've been
course.
learning so much and we're excited to learn. You know, we're new clinicians, so it's just cool being able to talk to so many knowledgeable people. So I think it's a really good opportunity for us too.
I love it. I love it.
Yeah,
All right, you guys go have a good night. Thank you so much.
Yeah,
We'll
thank you.
see you soon.
you too. Bye.
Bye.
Hey everyone, thanks for tuning into the podcast. Some thoughts to chew on for the rest of your day. What really stands out from this review is that cardiac risk assessment doesn't have to be complicated or inaccessible. Physical therapists have a range of evidence supported tools from simple screening questionnaires to advanced exercise, ECG testing that can really help guide safe and effective aerobic exercise and practice.
And you know what? Big thanks to the authors for their contributions to the field. And thank you, Karlyn Green, for joining us today. And thank you all for listening. Until next time, stay curious, stay evidence informed, and keep moving forward.